Inflammatory bowel disease, IBD, encompasses two major chronic inflammatory disorders of the gastrointestinal tract, Crohn's disease and ulcerative colitis. These conditions are most common among Caucasians and individuals of Ashkenazi Jewish descent, with onset typically between the teenage years and the 50s. In patients with a known history of Crohn's disease who present with acute abdominal pain, small bowel obstruction, SBO, should be suspected. This is caused by transmural inflammation leading to stricture formation. Transmural inflammation in Crohn's disease can also result in fistulas, abscesses, and draining sinuses. In contrast, ulcerative colitis does not cause fistulas because inflammation is limited to the mucosa and submucosa. Comparison of ulcerative colitis and Crohn's disease. Site of involvement. Ulcerative colitis, UC, always involves the rectum and extends proximally in a continuous pattern. It usually affects only the colon, with inflammation and ulceration limited to the mucosa and submucosa. Crohn's disease may involve any part of the gastrointestinal tract, most commonly the ileocecal region, in a discontinuous skip lesion pattern. The rectum is often spared. It causes transmural inflammation, which may lead to fistulas to other organs. History and examination. UC presents with bloody diarrhea, lower abdominal cramps, tenesmus, urgency, and systemic symptoms such as orthostatic hypotension and tachycardia. The physical exam may show abdominal tenderness, frank blood on rectal examination, and extraintestinal manifestations. Toxic megacolon may occur, and endoscopic or rectal tube procedures should be avoided due to perforation risk. Crohn's disease presents with abdominal pain, abdominal mass, low-grade fever, weight loss, and watery diarrhea. On examination, patients may have fever, tenderness, palpable mass, perianal fissures or tags, fistulas, and extraintestinal features. Extraintestinal manifestation. Both conditions may present with aphthous stomatitis, episcleritis uveitis, arthritis, primary sclerosing cholangitis, erythema nodosum, and pyoderma gangrenosum. Crohn's disease additionally causes fistulas to the skin, bladder, or between bowel loops. Diagnosis. Ulcerative colitis. Workup includes CBC, abdominal X-ray, stool cultures, ova and parasite exam, and C. difficile assay. Colonoscopy typically shows diffuse, continuous rectal involvement with friability, edema, and pseudopolyps. Diagnosis is confirmed by biopsy. Crohn's disease. Same laboratory workup as UC, but imaging often includes an upper GI series with small bowel follow-through, which can reveal string sign due to strictures. Colonoscopy may show aphthoid, linear, or stellate ulcers, skip lesions, cobblestoning, and non-caseating granulomas on biopsy. Creeping fat may be observed intraoperatively. Treatment. Ulcerative colitis, treated with 5-acetylsalicylic acid, ASA, agents such as sulfasalazine or mesalamine, given topically or orally. Corticosteroids are used for flare-ups. Immunomodulators, e.g., azathioprine, and biologics, e.g., infliximab, are used for moderate to severe or refractory disease. Total procticolectomy is potentially curative and may be required for long-standing, fulminant colitis or toxic megacolon, as well as for cancer prevention. Crohn's disease, managed similarly, but biologics, e.g., infliximab, are considered first-line for moderate to severe disease. Immunomodulators like azathioprine are used for maintenance. Corticosteroids are used for acute flares. Surgical resection may be required for complications such as perforation, stricture, fistula, or abscess, but it is not curative because Crohn's disease can recur in other areas. Incidence of cancer. Ulcerative colitis, significantly increases the risk of colorectal cancer and long-standing disease. Monitoring involves frequent fecal occult blood testing and yearly colonoscopy with multiple biopsies after 8 years of disease duration. Crohn's disease. The risk of malignancy is lower than in UC, but still higher than in the general population.